Welcome back. We met earlier when we talked about which beta cell therapy option, so pancreas or islet transplantation, would be best in a patient with diabetes mellitus who also needs a kidney transplantation. In this lecture, we will focus on issues related to pancreas and islet graft function that occur later, so weeks to months after transplantation. But let's first see what you remember about the transplantation procedures and the early challenges of pancreas and islet transplantation. Now you are ready to move on to the late challenges for graft function that we observe several weeks to months after transplantation. This slide shows pancreas graft survival data from the American Organ Procurement and Transplantation Network. Pancreas graft survival is defined as insulin independence. The rapid drop in graft survival after transplantation indicates considerable early pancreas graft loss in 10 to 15% of patients. After 5 years, pancreas graft survival in simultaneous pancreas kidney transplantation, about 75%, is better than in pancreas after kidney transplantation, with a pancreas graft survival of about 63% after 5 years. While tens of thousands pancreas transplantations have been performed worldwide, less than 3,000 islet transplantations have been carried out. So robust large data sets on graft outcome after islet transplantation, and in particular islet after kidney transplantation, are not available. This slide shows data from the Collaborative Islet Transplantation Registry. The left graph indicates that the minority of these islet transplantations are islet after kidney transplantation. The right graph shows that insulin independence is achieved in less than half of the patients, although improvement of islet graft outcome can be observed in more recent cohorts of recipients. Several markers can be used to monitor graft function. For both pancreas and islet transplantation, glucose, C-peptide and HbA1c are used as markers for endocrine graft function. After pancreas transplantation, serum amylase and serum lipase can be used. If the operation involves bladder drainage of the pancreas, urinary amylase can be used. So naturally, we would like to know why pancreas and islet graft function decline over time. Several factors could be involved. Acute and chronic rejection are important factors in pancreas and islet graft dysfunction, similar to kidney graft dysfunction, as you heard in a previous lecture. Unfortunately, detection and monitoring of ongoing pancreas and islet rejection is difficult due to the lack of sensitive and specific markers. When glucose concentrations rise, there's usually already significant damage to the islets. Increased serum amylase or lipase are indicators of acute rejection after pancreas transplantation. In simultaneous pancreas kidney transplantation, creatinine concentrations can be used as a surrogate marker for rejection of the pancreas. Immunosuppressive agents can be toxic to insulin-producing beta cells, in particular the calcineurin inhibitor tacrolimus. We will discuss the influence of immunosuppressive agents on glucose metabolism in the next lecture. Insulin resistance, caused by obesity, lack of exercise, or medication, such as steroids, can uncover marginal pancreas or islet graft function shown by rising glucose concentrations. Whether insulin resistance per se actually speeds up graft dysfunction is not clear. Recurrence of autoimmune diabetes is another factor. Since new beta cells are transplanted in recipients with severe beta cell failure due to autoimmune diabetes, it is logical to speculate that these new beta cells are rapidly attacked by an activated autoimmune system against beta cell epitopes. However, specific destruction of the insulin-producing beta cells is uncommon in pancreas transplantation. As the decline in graft function in islet transplantation is more pronounced, it cannot be excluded that recurrence of autoimmunity against beta cells plays a larger role after islet transplantation compared to pancreas transplantation. Some factors are specific to pancreas transplantation. Thrombosis is probably the most important factor in pancreas graft loss. After the immediate post-operative period, rejection and inflammation are the most important causes for graft thrombosis. Graft pancreatitis could be due to anatomical issues, constipation, small bowel obstruction, abscesses, pseudocysts, or other causes. Besides these factors, HLA sensitization is an issue that is relevant after every transplantation, as you heard in a previous lecture. It should be realized that exposure to HLA mismatches is higher in pancreas after kidney compared to simultaneous pancreas kidney transplantation. Since several donors are often necessary in islet transplantation, as many patients receive 2 or sometimes more islet infusions, exposure to HLA mismatches is even more increased, although tissue volume is much smaller. You have now received information on the different transplantation options in patients with diabetes who need a kidney transplantation. And you heard about the early and late challenges of pancreas and islet transplantation. Pause the lecture, grab a pen and piece of paper, and write down what issues you would discuss with your patients. Welcome back. The number of procedures and risk of complications need to be taken into account when deciding on the best transplantation strategy for your patient. Pancreas transplantation has a substantially increased risk of complications compared to islet transplantation. There is an increased risk of early graft loss in pancreas transplantation, but the chance of insulin independence is higher and late graft loss is lower compared to islet after kidney transplantation. Monitoring of rejection is more difficult in pancreas after kidney and islet after kidney compared to simultaneous pancreas kidney transplantation. And in pancreas after kidney and islet after kidney transplantation, there is more exposure to HLA mismatches. So, in this lecture, we discuss challenges in pancreas and islet transplantation that are performed in addition to kidney transplantation. What are the key points that you should remember from this lecture? Most importantly, the risk-benefit ratios should be carefully weighed for the different beta cell therapy options. Pancreas transplantation has a considerable increased risk of complications compared to islet transplantation. But graft outcome in simultaneous pancreas kidney transplantation is superior to pancreas after kidney and islet after kidney transplantation. This concludes our lectures on patients with existing diabetes before transplantation. However, the topic of diabetes is not finished yet. In the next lecture, we will discuss the development of diabetes after solid organ transplantation.